is just to give you an example of it, okay? So when we think of something like primary screening, it's where you identify that something is a carcinogen, and then you remove that from that patient's lifestyle or remove the exposure of it. The best way to think of it is the smoking cessation program. We know that cigarettes contain carcinogens. If a person is smoking, we remove that. That would be primary prevention. Secondary prevention focuses more on the early detection of different types of cancers. So what I've kind of listed on the next slide, and you don't have to remember this, these are the guidelines, and these are old, so they've probably been updated since then. But when women get a mammogram, that would be an example of a secondary type of screening because they're undergoing diagnostic tests to identify and catch cancer early. A colonoscopy is an example of a secondary type of screening. Question?
Yeah, so actually, like, I heard earlier this year the colorectal screening, that they go up to 35, which is pretty young, but they think that it's a lifestyle associated, like, factor, because there's so much more colorectal cancer in younger people than, like, historically, so.
I remember.
Did up, like,
Yeah, and this is from 2009, so I know they've changed it since then. I remember going with my mom to get a colonoscopy, and I think at that time when we were looking at it, they almost felt like if you live long enough, your likelihood of developing colon cancer is pretty high, just because of the exposure to the different substances and preservatives and things that you're taking in the diet. So it doesn't surprise me that they moved it back to 45. I heard that as well. Kind of feels young, but yeah. The colorectal cancer is can be such a preventable cancer if you get the colonoscopy. They find polyps and things like that. Those are things that can be removed during that process. So these guidelines are set into place so they can detect abnormalities early and then treat them so that they can reduce the risk of developing cancer in the future.
Yeah, but for example, I know that you said it's outdated for cervical, like Brazil, the adolescent vaccine. Like here, you go to your doctor, oh, you're young and you look healthy, so it just comes, like my doctor said, if it's too long, you know, so like I don't care, I pay out of pocket
To have
a prescription, right? So I don't know.
You know, and a lot of things, I don't want to say this, but some of it's true. A lot of things is so, with cancer, is a lot of trial and error. You know, I don't think we know the best way to treat every single type of cancer because we'll talk about it when we talk about treatment. Often people are on different chemotherapy cocktails, you know, or different combination of medicine. Sometimes we are trying to determine what's the best way of treating, but again, individuals act differently, and I don't really know the best way. You know what I mean?
But starting every year
Would help, yeah. Well, you know in America what part of that is money, unfortunately. Yeah. And sometimes that's where you have to kind of do what you feel is best. Like if you have a family history or something of cervical cancer or a particular type of cancer, you don't have to follow the screening guidelines. You can ask, or you'll probably have to pay out of pocket, but it's better to know, right? Yeah.
there's a trade-off of, like, in the literature, right, that for some people, they have a tumor that is being detected that will be, like, not the thing that kills them. Like, and, like, early screening is great when you actually have a cancer that is highly likely to develop to kill you, but if you have a tumor that is probably going to stay benign, you probably see your family making that decision. But, like, are you over-intervening for some percentage of people, like subjecting them to treatments that are not necessary, because that tumor is not ultimately going to be one that develops to kill them? So this is like really common in like breast cancer literature to have this discussion because it's like so in your face, like publicly, like everybody knows, like I have to do my screenings, all this stuff. But there are a lot of people that have like carcinoma in situ, like Dr. in situ, that probably aren't going to get like a huge cancer that kills them. Like, but we're removing it and treating it with radiation, like all those quality of life issues in the short term. So
Yeah, you have
It's
to
like
outweigh
your
the,
personal, like, how much do I want, like, if I were 80, I probably wouldn't care. I'd be like,
Right.
I'm just gonna go off and like travel. But at 30, like, yeah, I probably
I think
want
that
to take
raises
those
a good
6 just in
point. Yeah.
case. Like,
I think that raises a really good point. You're right. So they're hesitant to really be, lower this, or make the screening more routine because then they're going to maybe overcatch things or catch things that probably don't need an intervention.
yeah, so I went to a public policy talk on healthcare by like 4 months ago. And that was one of the ways they said like cost of healthcare, like part of it driving is like, are we over intervening on people that may not necessarily like have something that's
That's a really good point. But I don't know because I might be the person that would want the over intervention.
Yeah,
It's
like hard to say.
It's a really good point, right?
Yeah.
Right. All right, so warning signs of cancer, and we'll start off with these guidelines. And these are very generic, but we'll kind of go through them, and then we'll talk about more specifics as we get into the lecture. But warning signs could be something as simple as a change in bowel habits. Changes in bowel habits could be indicative, like constipation or blood in the stool, may be indicative of things such as colon cancer. Sores that do not heal or sores that bleed can be indicative of like skin cancer. White patches on the inside of the tongue is often known as leukoplakia, and these they could be like precancerous oral tumors. We'll talk about leukoplakia, perileukoplastia a little bit later. You could have an unusual bleeding and discharge, and again, this is going to depend on where that's coming from, but a lot of times if someone ends up having uterine or cervical cancer, it may be bleeding outside of the normal times. If you're coughing up blood, they may be indicative of lung cancer, so it depends where that unusual bleeding and discharge is coming from. Thickening or lumps in the body is often a late stage of cancer. Okay, usually when a person can feel the lump through the body, that indicates that the cancer has been in a later stage, has been growing for a while. Indigestion or difficulty swallowing could be indicative of something like throat cancer. Recent changes in a wart or mole, probably skin cancer, right? And a nagging cough or hoarseness could actually be related to lung cancer. The point in going over those warning signs is that some of them can be very subtle and some of them can be very kind of generic. So when we're working with clients and we're working with patients and even ourselves, you want to make sure that you're paying attention to some of those warning signs, some of those changes. We touched on cells just a little bit, but we'll come back to it. So that diagram on the right-hand side just kind of goes over the difference between what a normal cell looks like and what a cancer cell looks like. And you can see that in the normal cell, you have a single nucleus. It's a circle format. You have your cytoplasm, which is around your nucleus. All that is very normal and uniform. Versus in your cancer cell, you can see that the cytoplasm or the fluid around the nucleus is smaller. The cell itself is misshapen, and it can actually have more than one nuclei in it. So it just kind of goes to show you the mutation that's occurred in that DNA, and that's what's causing the cancer. I do want to go over the different types of cells. We have 3 cell types that we'll focus on. The first one are your cycling cells, and these are your cells that are going to divide continuously, okay? These are your cells that you'll find in your skin, cells of your hair, cells in your GI tract. They continuously divide. And this is going to be important when we begin to talk about treatment for cancer. You'll notice that our chemotherapy and our radiation therapy are going to affect your cells that rapidly divide, okay? You also have what's called your non-dividing cells, which means they divide before they specialize, but once they specialize, they don't divide anymore. So when we think of our non-dividing cells, an example is our nerve cell. Your resting cells, they remain dormant, which means they're not dividing unless they really need to. So when we think of these, we think of like our liver. Remember our liver, we said that if it needs to regenerate, it can up to a certain point, but it's not constantly regenerating, okay? Then you have two kind of genes for cellular growth, okay? You have what's called your oncogenes, which stimulate cellular growth, and your suppressors, which are going to suppress cellular growth. So what actually happens in cancer cells is that your oncogenes are stimulated. Your oncogenes, which are stimulating growth, those are stimulated, and your suppressor genes are suppressed. Okay, so in cancer, we have the excess growth, so our oncogenes are stimulated, and our suppressor genes are suppressed. This is what we saw in the video. Your cancer cell is going to reproduce at the uncontrolled rate, and it becomes what we know as autonomous, okay? And what that means is that it only pays attention to itself. It's selfish, okay? So normally, once a normal cell touches another cell, it'll stop growing. It sends different hormones and things to tell it when to stop growing. But the cancer cell becomes autonomous. It doesn't listen to those other cues. It secretes its own growth factor that tells it to continue growing. And that's how we have the development of the tumor. There are 3 stages and what we call carcinogenesis. And that just means the transformation from a normal cell to a cancerous cell. Okay? So 3 stages of carcinogenesis. And I'm going to warn you, because I've done this. If you look this up, this is a very complicated process. And I'm going to admit I'm not the expert on carcinogenesis. So I'm just going to give you the basics of what I want you to be familiar with for the exam. If you find it very interesting, I do encourage you to kind of go read up on it, but it does get a little confusing. So just for the exam, I'm going to give you the basic information that I want you to be familiar with, okay? During the initiation process, a normal cell is exposed to the appropriate dose of the carcinogen. Appropriate dose of the carcinogen. Why do I keep saying appropriate? Yeah.
Like a small thing that your body can probably naturally off.
Exactly. So the appropriate dose, so a certain amount or continued exposure, whatever that carcinogen is. Okay? Once it's exposed to that normal cell, it then begins to initiate changes within the DNA of that normal cell. It initiates changes within the DNA of the normal cell. Okay, so then we move on what's called the promotion phase. This is usually the longest phase. This is often when cellular growth is uncontrolled. A person may or may not know that they even have cancer, but there's this kind of uncontrolled growth that's occurring. At this point, we have something called promoters, and we have something called, we have benign or cancerous promoters and non-cancerous promoters. Your promoters are like hormones or different substances that will induce genetic mutations, okay? So some of those promoters are cancerous, some of them are non-cancerous. If you have non-cancerous promoters, what happens is you form what's called a benign tumor. You guys know what a benign tumor is, right? Non-cancerous, it may cause discomfort, but there's no hint of cancer or there's no invasion or metastasis, okay? It's just a tumor. Your cancerous promoters are going to form what's called a cancerous tumor. But in this stage, what happens is they form just like a pre-neoplastic lesion. So if you kind of look at that third stage right here, it's not actually a tumor yet, but there's genetic changes, there's this uncontrolled cellular growth, and you have this kind of like lesion that's formed. So it's not an actual tumor yet, it's more like a lesion. When you move into the third stage of progression, this is where the lesion turns into more of a tumor. So basically, if it's just a benign tumor, it really just stops at the promotion phase. If you have the cancerous promoters, you get the pre-neoplastic lesion, and then in the progression phase, it actually forms the tumor, the cancerous tumor. Does that make sense? Because this is carcinogenesis. So even though we talked about non-cancerous promoters, our non-cancerous promoters forms a benign tumor, and that's it, okay? Our cancerous promoters form that pre-neoplastic lesion in the promotion phase, and then once it gets to the progression phase, that lesion turns into a tumor. That tumor can either invade nearby tissue, or it can metastasize to different areas in the body. That's a very simplified version of carcinogenesis. Does that make sense? So there are certain characteristics that you'll see in each stage. In the first one, they're exposed to the carcinogen, but it has to be the appropriate dose. Then we start to see the changes within the DNA. In the second stage, promotion, the cells are exposed to the promoters. Some of them are cancerous, some are non-cancerous. In this stage, we get the formation of that pre-neoplastic lesion if it's a cancerous promoter. In the progression, this is where that lesion becomes a tumor. The tumor can either invade or metastasize to different parts of the body. So there are certain characteristics that I want you to be familiar with for each stage. So what happens if you have a benign tumor and it doesn't go to cancer, but it's just a benign tumor? What happens? Right, exactly right. So some benign tumors, depending on where it's at, if it's not causing pain or discomfort, they don't have to do with anything with it. But if it's in certain organs or certain areas where it causes pain, then they will remove it.
In a benign tumor, is your risk of getting cancer?
So here's the thing, and I'm going to speak from my experience. So they do have benign tumors that are called fibroids, and they're benign tumors that are found in the uterus. They do not turn into cancer, but when you look at the literature, it seems to say that there's like maybe a 1% or less chance of that person developing cancer in the future. So I think it depends on where, and it could increase their risk, but from what I've seen, it's not a significant increase. Now, if you have something like a colon polyp, that's different, because polyps really can turn into cancer. They're not really benign tumors. They are kind of like precancerous growths that can become colon cancer. So polyps are a little bit different from like benign tumors. A good question. So how do we know that someone has cancer, or how do we diagnose a tumor? So there are certain blood tests that you can do, and usually what they'll do with a blood test is do like what we call a complete blood count. They may also look at some of the cells under a microscope, and if they're looking at the cells, what do you think they're looking for? Yeah, the abnormal ones, right? Because we kind of know they're misshapen, they can have more than one nucleus, they're going to look different from the normal cells. So they can actually look at the cells under the microscope. They can do what's called cytological tests, which usually involves like a biopsy of the cells or the fluid. So they can take fluids from the body, they can take cells to determine if they have any features of cancer in them. Imaging is probably one of the most common that we're used to. Imaging involving like MRIs, X-rays, mammograms, all of those would be examples of different imaging techniques. And this is usually used to identify one, the location of the tumor, but they can also look at the size of the tumor this way as well. They do have biochemical tests, which they will take they'll do like different blood tests to determine levels. So when we think of something like PSA, which is your prostate-specific antigen, this is often taken in men. These levels are often increased if a man has prostate cancer. But it's not like an indicative diagnosis, but it usually tells us that there may be a risk of prostate cancer. Other ones are the CA125, which is a protein secreted by the ovarian cells, and all this is in your notes. And then you have the carcinoembryonic antigen as well, which is elevated when there's colon cancer. So there are some things that we can look at, levels in the blood that we can look at to determine if someone possibly has cancer, but there still needs to be other methods to definitively diagnose it. So when we think of cancer, sorry.
So they have like the metastasis staging on the bottom.
Sorry, yes, thank you. So this is important. So I'm going to tell you the very basics of this. We have what's called a tumor node metastasis staging system, or TNM, okay? When we look at TNM, it usually tells us, okay, the presence of the tumor, if the tumor has metastasized to different nodes and lymph nodes. And why would we want to know if it's metastasized to different lymph nodes? Right, if it's gotten to lymph nodes, it could get in the lymph fluid and spread. And then we want to know the level of metastasis. So has it metastasized to another organ, okay? This is often done by the oncologist. They will grade someone's tumor on this. The location or size of the tumor, has it metastasized to any lymph nodes, and has it metastasized to any other organs, okay? The reason they do this is because this is used to help decide how we treat an individual's cancer. So if we know that your person has uterine cancer, it's a certain size, it's not metastasized to lymph nodes, it's not metastasized to other organs, we can say this is how you treat it. So if we get another patient at that same stage, then we know how to treat that person as well. So it's often used to help us determine how to treat an individual's cancer. So it kind of tries to set in some standardization. When I work at the hospital, they have what's called like a tumor oncology board. So once someone was diagnosed with cancer, and they would stage them using the system, then they would meet together with other clinicians to determine the best mode for treatment. So this is what this is used for. All I want you to know is that it's a staging system, okay? And we use that to determine how to treat an individual's cancer. Okay, so clinical manifestations. Pain. When you think about cancer, you have to think about one of the kind of things that patients experience is pain, because that tumor is not supposed to be there. So depending on where it's located at, it can cause pain in that area. So our patients will often experience a lot of pain depending on the location and size of the tumor. They're also at risk for infection for several reasons. Infection can be related to the type of treatment that they're receiving. Maybe the treatment has damaged their immune system, or sometimes patients have cancers of the blood system, like they may have a cancer of the white blood cells, and cancers in that nature would already decrease the immune system and the person's ability to fight off infection. So a lot of time when we're working with cancer patients, they are what we call immunocompromised, which means their immune system is not functioning normally and they're at risk for multiple infections. Our patients are often anemic. Again, they're anemic for several reasons, because probably they may not be consuming adequate nutrition, their treatment may damage their red blood cells, and sometimes they actually have cancers of the blood system, which would cause anemia. Fatigue. Our patients are often very tired and weak because of their treatment, causes a lot of extra stress on the body, as well as being mentally fatigued. Cancer is a very mentally draining condition. Malnutrition, again, because of the treatment, and we'll talk about that. Some of these cause such severe nausea and vomiting that patients are just unable to eat. Cancer cachexia is more than just malnutrition. It's the actual wasting that we begin to see in patients. And this is the point when we're getting to cancer cachexia. It's really very difficult to reverse that process. So cancer cachexia is, of course, the malnutrition, but it's the lean body mass loss, it's the fat loss that we see, it's the very high calorie and protein needs that patients have, it's the body's preference to utilizing protein as an energy source. All of those contribute to more than just malnutrition, actual cancer cachexia. What's another condition where we see cachexia at? It's just a side note. Think of another condition where you see people get very, very, have a wasted appearance toward the end of their disease. AIDS. Yeah. So cachexia is common both in cancer as well as in HIV and AIDS. Well, not HIV and AIDS, but we'll talk about the difference next time. Okay. So how are cancers named? They are named from the tissue that they arise from. So for instance, your epithelial tissue, that's known as a carcinoma. The suffix is always oma. Oma means tumor. You think that's medical terminology. So epithelial tissue is a carcinoma. Connective tissue is sarcoma. Lymphatic tissue, lymphoma. Gliomas, and then any blood-forming organs, like of the red blood cells, white blood cells, flesh, are called leukemias. Okay, so that one's a little bit different. All the other ones end in omas. So be familiar with the naming. Okay, so when we think of cancer, I don't want to show that again. What do we think of in terms of treatment?
Chemo.
Chemo? What else? Radiation and surgery. 3 forms of treatment that we're going to talk about. Chemo, radiation, and surgery.
Or immunotherapy, because James Allison and Anderson won the Nobel Prize last year.
Do you want to tell us a little bit about it?
Yeah, so he discovered T cells, like T cell receptor, which is part of how T cells are activated to like fight off infections. But your body also sends around some cells looking for like weird cells of your own to try to get rid of them. And so he did all this work over his career to understand how T cell receptors activated, other factors on T cells that are involved, and then like how can we take that information and use that to create a targeted therapy to cancer. So like, yeah, he's got a beard and he plays in a band. Apparently, like when he was a postdoc and stuff, he sounds super cool that he won the Nobel Prize last year.
So I just want to make sure I understand. So he takes the T cells.
Yeah.
And he.
The long-term goal would be, I think, to like engineer T cells to
target
recognize that specific cancer.
Gotcha.
So like you need to be able to understand like you did it originally for like the biology of like how T cells work, and then over the course of his career, like we kind of like all the technologies to try to make that into the therapy.
So did he test it on a specific type of cancer? You know?
I don't remember. I know they're doing some immunobased therapies. But yeah.
It's pretty cool.
Yeah. I mean, he's been in Houston for a long time. He's worked for Anderson for a long time. Like, a Nobel Prize, like, amazing.
Yeah, it's pretty cool. And it's even going to be cooler when we talk about the fact that a lot of the treatment is not targeted.
Yeah.
And that's why we have so many side effects of cancer. So a targeted form of treatment that would only target the cancer cells and save the healthy cells would be amazing.
unfortunately. I mean, that's a real treatment, but it's so expensive that people, like, given the option, they're gonna go with general.
Right. Right. It's gonna take a while before it gets more reasonable for the public. If. Okay, so we'll start off with our traditional methods. Unfortunately, we won't talk about immunotherapy yet, but maybe years from now, that'll be part of this. But we'll focus on surgery, chemo, and radiation. So with surgery, there are a couple of different terms that I want you to remember, okay? When we talk about surgery, there's primary surgery, and that means that's all you do. You're gonna have surgery, remove the tumor, that's it, okay? Okay, the next one is adjuvant. And this is how I want you to remember this term. Adjuvant means after, okay? AA. I always have to do things to make me remember. Adjuvant means after. So if it's adjuvant surgery, that means surgery comes after another type of treatment, okay? So adjuvant surgery, an example may be, and I'll give an example of someone I worked with a while ago. I worked with a colleague of mine, and her young child actually had a tumor on their neck, very young child. And so because of the location of the tumor, and it was around such significant arteries, they didn't want to go in and do surgery right away. And he was very small. So what they decided to do was to do chemotherapy first to reduce as much of the size of the tumor as they could. Then once they got it down to a decent size, they tried to go in and do surgery. That would be an example of adjuvant surgery. Do chemotherapy initially to maybe reduce as much of the tumor as you can, and then you go and follow up with surgery to remove the remainder. Combination just means you're using more than one treatment. Okay, so combination means you're using surgery and something else. That's all combination means. Salvage means that you do an extensive surgery later to treat a condition. So the best example is the breast cancer. So you go in and you do a lumpectomy initially, but then you realize you haven't gotten all the cancer, so then you have to go back and do a mastectomy. That would be an example of salvage surgery. Palliative surgery is just like palliative care. This is designed only to cause comfort. It is not designed to heal cancer or to cure cancer. We often use palliative treatment if we know that the cancer is incurable. So when you think of palliative surgery, sometimes we have individuals that present with cancer in their spine, and maybe it's so extensive, we know that we're not going to be able to cure the cancer, so they'll go in and they'll remove some of the tumors just to give the patient comfort, so they're not in extreme pain. So palliative surgery is not designed to cure the disease, it simply gives the patient some level of comfort. We're going to touch on several types of cancer that are treated by surgery, okay? And when we touch on these cancers that are treated by surgery, we're also going to talk about some of the side effects that the patients may experience. So a big one is head and neck cancer. Imagine if someone has cancer of the head or neck, that's probably going to have a significant impact on their nutritional status, right? So this is one cancer, when I worked on the floor, that we decided to be extremely proactive with. We knew that if patients had cancers like of the throat, of the esophagus, that they were very likely to become malnourished. So for these patients, we're even more proactive. We try to make sure that we're giving them a feeding tube, we're doing all that up front in order to prevent malnutrition. So if someone has cancer of the esophagus, of the throat, they may go in and they may remove the tumor through surgery, but they may experience certain side effects. Number one being dysphagia. You guys know what dysphagia dysphagia is? Altered taste. Okay? So one of the side effects is now that you have altered taste. So they've gone in and removed the tumor, but it's affected their taste buds. So now we want them to eat to heal, but their taste is altered. So it impacts their ability to consume adequate nutrition. The other thing that we see in these patients, or that we could see, is something called xerostoma, which is what? Dry mouth. And it's more than just, I'm thirsty, so I'm going to carry my water bottle with me. This is usually some sort of damage to the salivary glands. So there's a decrease in saliva production. So this creates a very extremely dry mouth for these patients. Your mouth is dry. Again, it's difficult to what? Swallow, right? Question?
I was just gonna ask, are these permanent?
They can be. Yeah. So often what we'll do, and this is listed at the end of the lecture, but we might as well talk about them. We'll put things in place to combat them. So if someone is having dysphagia, they have altered taste, sometimes what we can do is maybe just give, like, sometimes cold foods are more tolerated, avoid certain foods that may have a metallic taste. We'll try to do things to overcome the fact that they have kind of the altered taste. Oftentimes what we see in cancer patients is that they like things that are a little bit milder, not very sweet. So we'll try to kind of get their preferences so we can overcome the fact that they're having the dysphagia. Xerostoma, what do you think we could do for someone that has a xerostoma, or extremely dry mouth? There is a spray, yes. You can give them mouthwashes or sprays that help with it, yes. What else could you do?
More citrusy fruits.
You could. If they didn't have any oral irritations, you could do like citrusy fruits, like things that will kind of enhance saliva production.
Do you like ice chips?
Ice chips? Mm-hmm. What else? No. Candy. Stuff on ice chips. All of those things will kind of enhance saliva production. So that's how we would treat them. That's how we would help them.
So we're gonna eat them, if you had them to like swish them up and sit in your mouth and take like a whole bite and then like.
Usually we'll have them like suck on ice chips throughout the day, so it just kind of helps. But probably the best thing are the mouthwashes and sprays. Yeah. I don't know if you ever been like in the
I've seen them,
the biotin or something like that. There's one that's specifically for dry mouth. Okay, so one of the two complications from head and neck cancer could be the dysphagia or the xerostoma. Esophageal cancer is also a cancer that's treated with surgery, okay? Risk factors for esophageal cancer, I'm sure this is not surprising to you: smoking, alcohol consumption, a diet low in fiber, and fruits and vegetables, right? Causes many types of cancer. But what's this Barrett's esophagus thing? What is this?
Well, like when you have heartburn, like chronic heartburn, and all the acid goes up and touches the cells at the bottom of the esophagus. Like over time, they start making changes to try to survive constantly, like getting exposed to heartburn. And so it's not necessarily cancer, but it's really tough.
Yeah,
They're like constantly changing to survive.
exactly. So what Christine's telling us is that the stomach juices and everything are very acidic, right? And the stomach's designed for that. But sometimes when you have a constant or like long-term heartburn or reflux, that acidic content is coming back up into the esophagus. The esophagus is not designed to handle the acidic content like the stomach is. So the cells at the bottom of that esophagus become mutated. They've got to change so they can handle the acid that they're constantly being exposed to. So as they mutate or change, that change predisposes an individual to developing esophageal cancer. Okay, so Barrett's esophagus is one of the risk factors, and Barrett's esophagus is just a long-term reflux, long-term heartburn. Sometimes patients will have cancer of the stomach, okay? And we'll treat that with something called a gastrectomy. Gastrectomy indicates what? Removal of the stomach. So it can be a partial gastrectomy or a total gastrectomy. Okay, so partial means part of the stomach remains, total, they remove the entire stomach. So because of this, patients can have several symptoms, and some of these seem contradictory, so we'll talk about them. Sometimes patients will have what's called dumping syndrome, which literally means that the food just moves too fast through the GI tract. So as soon as they eat it, particularly things that are high in like concentrated carbohydrates, they'll have to go like straight to the restroom. They'll have diarrhea. It just moves too fast through the GI tract. Some patients who have gastrectomies, and this is usually in patients that have the partial gastrectomy and in patients that are a little bit older, they'll have what's called delayed gastric emptying. Okay? Delayed gastric emptying means the food sits in the stomach for longer than it should. So it just sits there. The reason that you see these very opposite kind of potential actions is because the GI tract is innervated by the nerves. So depending on what nerves are cut, what nerves are altered, you can see two very different responses. You can either see where the food is moving too quickly through the GI tract, or you can see where it kind of sits in the stomach for a longer period of time. Does that kind of make sense? With either one, the partial or total, they're going to have early satiety, which means they get full quickly. This definitely makes sense because they don't have really a reservoir to hold the food in. So of course they're going to get full a little bit quicker than other people would. They may also experience some nausea and vomiting. So let's talk about some of the things we could do. So if we have a patient that's having dumping syndrome, and we know that dumping syndrome is kind of the risk is increased by consuming a lot of concentrated carbohydrates, then we would probably tell them, don't consume like a large beverage, sugary beverage, a large sugary foods, very concentrated carbs all at one time. Don't consume large amounts because that will kind of increase the risk of dumping syndrome. If someone's having issues with delayed gastric emptying, where the food kind of sits in the stomach, what do we tell them?
Eat smaller meals.
Smaller meals, definitely. What else? Huh? Fiber would help, right? Reduce carbohydrates, but nah, that's more for the first one. But have you ever noticed when you have like a really high fat meal, what happens to it? Sits in your stomach. So usually like a lower fat, a little bit more fiber, and smaller meals will help if they're having that delayed gastric emptying. Early satiety, small frequent meals, right? Those are ways that we can combat this. No, I just would give them like maybe smaller portions and particularly watching those. Choose more like complex carbohydrates versus the concentrated ones. Would probably tell them to stay away from things like juice or regular beverages because that's just going to go straight through. Huh? That could happen. What do you think?
We're doing a class activity after.
More damage to the stomach?
Today is like a long lecture.
It could cause things like gastritis, like irritation and inflammation of the stomach lining. Yes. Where else do we see delayed gastric emptying at? You know another condition? This is a total side note, but have you ever heard of delayed gastric emptying in patients that are diabetic? No? got a little time. So side note. So a lot of times when people are diabetic, if they don't control their blood sugars, it damages their vessels, right? It damages their nerves. It damages their vessels in their eyes. That's why they go blind. It damages the vessels leading to their kidneys. That's why they develop kidney disease. It damages their vessels in their lower limbs. That's why they have to get their limbs cut off. Uncontrolled blood sugars damage your blood vessels. It damages your nerves. Your GI tract's innervated by nerves, right? So a person that's had uncontrolled blood sugars for a long time or who's had diabetes for a long time can develop delayed gastric emptying because the nerves that go to the stomach don't work. So for those patients, we often have to recommend a little bit more fiber, lower, what was I going to say? A little bit more fiber in it, and we have to recommend a lower fat diet for them to help with that. Okay, so same kind of concept, it's just for different reasons, but it's caused by the damage to the nerves. All right, any questions on gastrectomy or the symptoms? Yes.
For the gastric cancer, what
The risk factors, of course, are going to be related to diet. Genetics are going to cause it. Sometimes alcohol or drug use can cause gastric cancer. Those are probably the main things. It's probably related, as most cancers are, to lack of physical activity and being overweight. But with gastric cancer, you particularly see the alcohol and drug use and the diet itself. Intestinal cancer, is also treated by surgery. And what they'll do is they'll go in and remove portions of the intestine. So we call that a resection, okay? So resections may cause steatorrhea or malabsorption. That makes sense, right? We've learned that. If you remove part of the place where the nutrients are absorbed, you're going to get malabsorption or you can get steatorrhea. And for that, well, you could not really give pancreatic enzymes. You may have to do some sort of like enteral feeding where the macronutrients are already broken down. That may be better tolerated. Persons with malabsorption may also require parenteral nutrition, depending on how severe it is. Intestinal cancer, the risk factors are, and you're probably going to get tired of me saying this, family history, diet, lack of physical activity, obesity, smoking. The only one that's different is irritable bowel disease. Are you guys familiar with that? Kind of the bouts of diarrhea, constipation that patients experience. So 2 things that we can do. It's called a colostomy or an ileostomy. Are you guys familiar with this process or what these are? A colostomy is when the rectum and the anus are removed, and the remaining portion of the colon is there's an opening with a bag in it. Okay, so that's where their stool would come. So they're bypassing the rectum and anus. They remove those portions, and they have a bag, and that's where the stool is collected at. Okay, colostomies are reversible. So if someone they're allowing the colon to heal after something, they can reverse the procedure if possible. And cancer is not always reversible, but if possible, it can be reversed. And then so the bag is just changed frequently because that's where all the waste would be collected at. You can also do an ileostomy, which is just a little bit more of the colon is bypassed. So with the ileostomy, they bypass the entire colon, the rectum, and the anus. Okay, still the same bag, it's where stool is collected. But with the ileostomy, there's an increased risk of dehydration because now we've bypassed the entire colon. Okay. And just with the ileostomy or colostomy, most of the time, once it's been established, which means once they've had it, they're used to it, they can follow a regular diet. So it doesn't really require a change in diet. Some individuals can't tolerate like gas-forming foods or a very high fiber diet, but for the most part, the diet overall is normal. Okay, pancreatic cancer. This is another type of cancer that's often treated by surgery. And we do what's called a Whipple procedure, okay? And I want you, if you have my notes open, if you scroll down to that very last point, or I can put it on the board. It's called a Whipple procedure, but it also has this other really long name. It's called a pancreatic duodenectomy.
See? Do you see? It's a long name.
Also known as the Whipple procedure. Same thing. Okay? Most of you guys are over there. Can you guys see it? Okay. Pancreatic duodenectomy. Same thing as a Whipple procedure. Okay? And my notes, it lists the things that are removed. The pancreatic head is removed. The gallbladder is removed. The duodenum is removed. The bile duct is removed. And sometimes they remove the gastric antrum, which is a portion of the stomach. Not all the time, but sometimes they'll remove a portion of the stomach as well. The thing about pancreatic cancer and this procedure, a couple of things. The incidence of pancreatic cancer is almost equal to the mortality rate. Why do you think that is? It's hard to diagnose. Okay, very, very hard. There's no screening methods for pancreatic cancer. It's very, very difficult to diagnose. So usually when it's diagnosed in the late stages. Okay. If they do diagnose it, and they may do what's called a pancreatic duodenectomy, which I told you what's removed, and basically you're rearranging the entire digestive system, right? So it's not surprising that these patients are at risk for malnutrition. So for these patients that have a pancreatic duodenectomy, we typically place what's called a jejunostomy tube, which is a jejunum and ostomy. So what do you think a jejunostomy tube is? Directly to the jejunum. Okay? So, so just so I'll explain, because we haven't talked about enteral feeding yet. With some enteral feeding, you have a tube that goes down your nose into your stomach or jejunum. Okay? And other instances, you have a tube that goes in your mouth, goes down into your stomach or jejunum. With the jejunostomy tube, there's no tube in your stomach or mouth. Just directly into your jejunum. Okay? So that's a jejunostomy tube. It bypasses a bunch of what's removed. It feeds the patient directly into the jejunum. Okay? So that's often what we'll do for these patients because they're at such high risk of malnutrition. We'll just go ahead and give them a jejunostomy. Other things that you'll see with pancreatic cancer, we know that the pancreas, we've already talked about it, controls insulin and glucagon production, so we probably will see that your glucose levels are going to be off, or they may even become what we call like a type 1 diabetic at some point because of the pancreatic cancer. And of course, without enzymes, their absorption is going to be affected, macronutrient absorption. And even if they're getting like the jejunostomy feeding, they'll probably need some sort of enzymes to help with absorption because it's not being released by the pancreas. Any questions about the types of cancer that are treated with surgery and any of the potential side effects or complications? Okay. All right, so our our next treatment is chemotherapy, okay? Chemotherapy is systematic, okay? So not systematic. It acts systemic. That's what I'm trying to say. Systemically means that it's going to affect all of the cells of the body. So remember when we're talking about immunotherapy and that's a targeted approach, chemotherapy is not targeted. It affects all of the rapidly dividing cells of the body. It affects rapidly dividing cells because cancer cells are what? Rapidly dividing. And right now, our chemotherapy is not smart enough to say only target the cancer cells. So it targets rapidly dividing cells. So it targets all of the rapidly dividing cells. Okay? Chemotherapy can be combination, which means you're using more than one type of treatment, using chemotherapy and something else. Chemotherapy can be adjuvant, which means chemotherapy happens after another type of treatment. So if we think about that, adjuvant chemotherapy would mean that they did some treatment first and then they followed it up with chemotherapy. So let's say that you did surgery to remove the tumor, but then you didn't get all of the cells, or you want to make sure all of the cells are dead, so then you follow it up with chemotherapy. That would be an example of adjuvant chemotherapy. Neoadjuvant is just a new term. Neo means it's first. Okay, so neoadjuvant would mean that you would do chemotherapy first, and then you would follow with another treatment second. Okay, but when we give chemotherapy, usually in an IV, then it's going to affect all of the rapidly dividing cells in the body. So with that being said, the side effects of chemotherapy are going to make sense to you. Okay? So if it affects all of the rapidly dividing cells, our patients will sometimes experience what's called neutropenia. Okay? Neutropenia is a low white blood cell count. Not account, but count. Low white blood cell count. And so if we know that the blood cells are rapidly dividing, it makes sense that your chemotherapy or agent or drug is going to target those white blood cells. So they destroy those white blood cells. Our patients may experience anemia, low red blood cell count. So our chemotherapy is going to target those red blood cells because they're rapidly dividing. Diarrhea and mucositis. Diarrhea because what innervates that are the cells of the GI tract are what? Rapidly dividing. They're constantly turning over. So if it's affecting the rapidly dividing cells of the GI tract, our patients may experience diarrhea as a result of the chemotherapy. Mucositis, if you look at that picture, it's just the ulcerative tissue and the oral irritation that occurs. Again, the cells of the GI tract, including the mouth all the way down, are rapidly dividing. So it's going to affect the cells of the mouth. This can cause oral irritations within the mouth. So our patients with chemotherapy may experience mucositis. What didn't I mention on here? There's one other one. And if you're looking at your notes, you probably already saw it. But what else is rapidly dividing? Or what else do we see as a result of chemotherapy? Hair loss, right? The alopecia, because the cells of the hair are rapidly dividing also. So all of those things that we see or hear as a result of chemotherapy are because those rapidly dividing cells are being affected by the medication. Okay. Radiation treatment, okay? Radiation treatment also affects the rapidly dividing cells. The difference is, with radiation treatment, it's a little bit more targeted to the area that's being affected. Radiation is where they're exposing the cells to, like, radiation treatment, okay? Radiation X-ray, radiation rays, that makes sense, to kill off the cells. It can be administered internally, where they have it implanted inside the body. I've not seen that clinically, or it can be administered externally. which means there's an external source that's providing the radiation. So this was a relatively new concept to me. When I worked at the hospital, we partnered with our radiation therapy center because we knew, remember I said that head and neck cancers are going to cause malnutrition. And so once we recognized that, we partnered with our radiation center. So I got to see a little bit of what that looked like. And I think it's important to share with you. So when you go in and say that someone has like a head and neck cancer that they're treating with radiation therapy, they often will go in and they're fitted with like kind of like a styrofoam kind of thing that holds them in place, right? So if there's a cancer right here, it's a styrofoam kind of band that will hold their head in place so that the radiation, there's a hole in it, can come directly to that area where the cancer is, okay? And then they walk into the room, there's a table, there's a big x-ray machine, they're fitted in their thing and they're sitting there. The radiation treatments are set by the oncologist, so they're usually ordered for a specified number of treatments, so maybe they're getting like 14 treatments, and then they get a certain strength of the radiation for a certain amount of time. Maybe they have their treatment for 30 minutes, 45 minutes, depending on what the oncologist orders. So they're sitting there with that on, and during this process, it's going to affect all of the rapidly dividing cells in that area. So if you're looking at a cancer that's here, it's affecting all of your oral mucosa. The radiation the treatment affects the skin, burns the skin. It affects may cause xerostoma if it's in this area. It may cause oral mucositis because it's affecting the tissues within my mouth, all of that rapidly dividing cells. If someone has radiation therapy maybe to the abdominal area, it's now affecting the area in that, the skin in that area. It could cause diarrhea. It could cause constipation, whatever, because it's affecting those rapidly dividing cells within that stomach or that region. So when we look at the complications of it, it is affecting all of the rapidly dividing cells, but it's a little bit more targeted in that it only affects the rapidly dividing cells in that area. Overall, though, the experience is a little bit overwhelming to see patients. So when we talk about things like fatigue, when we look at the common adverse effects, when we talk about things like fatigue, your body is physically fatigued, but there's also a mental fatigue that goes along with that process. Patients can develop the mucositis, which I told you if the radiation is being directed to that area. Patients can develop dysphagia, which is the altered taste, but only if the radiation is, in the oral region. They can develop xerostoma, dysphagia, which is difficulty swallowing, odynophagia, which is pain, and then esophagitis, which is just the irritation of the esophageal tract if that radiation treatment is being directed at that area. So if you've ever kind of seen someone undergo radiation, it's kind of a difficult process, both physically and mentally for that patient and for the family involved in that process. And what you have to remember is that as this is going on, what are we telling our patients to do in order to heal? What are we telling them? What are we telling them as far as food goes? We're telling them to eat. And it's hard when you're undergoing these things. It's easy to say you need the calories to eat, but we have to be aware of how do we get them to eat when they're undergoing these things. If you have oral irritations in your mouth, and I'm the dietitian coming in and say, okay, you need to eat, how does that translate to how do I actually help the patient? So a lot of times it's talking about strategies to figure out ways to help our patients eat. When there are issues like mucositis and there's these oral irritations in the mouth, our patients can't eat citrus foods. They can't eat things that would be spicy or irritating to them. Sometimes they can't eat things that are too hot. It needs to be at a nice kind of room temperature thing. Sometimes our patients have dysphagia where their entire taste is altered. So you may think that something's not salty or not too sweet, and they taste it and they can't eat it because it doesn't taste right to them. Their taste buds are altered. They may have xerostoma, which is again the dry mouth. So then we have to think, what can we do to increase their saliva production where they can't eat?
DeSantis also talked about the nausea and vomiting and the smell of food being very strong. So a lot of times they'll open the plates outside the room and let some of it dissipate before they actually give it to the patient.
That is such a huge thing. So I don't, if you've never been in the hospital, it may not make sense to you right now, but those trays, they come in, the food is hot, they put this top on them, and then they shove them in the cart and they close the cart. So all these smells are just together, okay? It's enough to make me nauseous and I'm not even sick. But on our cancer unit, we would actually take the tray out, open the tray before we walk in the room, and then go in the room. Because if you open that tray, that top off, right there, it's very overwhelming, and especially to them. It's very overwhelming. So we do have to think of anything like that we can that would help with the process. It can be extremely overwhelming. Mm-hmm.
For chemotherapy, would you use it when the participants that are under radiation effects is
It really depends, and sometimes it's a combination. Patients may have chemo, and then they'll follow it up with radiation. Yeah, so it's kind of hard to say. I guess I would say radiation would probably, like you said, if it's more localized and it hasn't spread, radiation would probably be enough. But sometimes they'll do chemo, and then they'll want to kill the last of the cells. So it could be either way. But usually, quite honestly, it's a combination of more than one temperature. Rarely is it just one. I was going to say something else. Yeah, so part of our therapy is just finding ways to get them to eat. We know that they have increased calorie needs, but they have a lot of things that makes it difficult for them to get the calories that they need in. Okay, so just a couple other things with radiation. These patients are at extreme risk for dehydration, okay? Just because if it's affecting their GI tract, either they're not able to take in enough nutrients, it's very difficult to, so they often have a very high risk of dehydration. And as it says on there, oral intake at times may be impossible because the esophageal tissues and the oral tissues are just extremely, extremely irritated.
I believe their skin's basically getting burned, but they also do the same thing.
Yes. Christine brings up a good point. Remember, radiation, they're rays, right? So they burn the skin. So if their skin is burned or damaged, they can also lose fluid through the skin as well. Oftentimes, if it's, depending on how much radiation therapy they're getting, and specifically, particularly if it's head and neck cancer, they will just go ahead and put in a feeding tube for them. A little bit about the nutrition care process. So, of course, our assessment essentially looks much of the same, looking at dietary intake, weight history. We want to pay particular attention to muscle wasting. What about ascites and edema? Why would we note those? Why would we care about those? Pancreas one, but what else? Think of lab values.
Like if they're experiencing ascites or edema, their weight that is not going to be.
That's a good point. Yeah. So if you're experiencing ascites or edema, your actual weight is not going to reflect your energy source, right? It's not going to be a good one. Okay. Good. What else? What might cause that edema in particular? Lab values. Think of something that's made in the liver. Do you remember in the assessment we talked about albumin? What happens to albumin levels when there's physiological stress? It goes down. body stops making it, right? Not because they're malnourished, it goes down because the liver stops making it, right? When albumin goes down, then there's what we call third spacing. Albumin holds fluid where it's supposed to be. It holds the intravascular fluid intravascularly, it holds the extravascular fluid extravascularly. But when the albumin level decreases, sometimes we see that the fluid leaks out into third spaces and causes edema. So sometimes these patients, because their albumin level is going to be low, may begin to experience edema. Make sense? And then we need to know that if they're experiencing edema or ascites, their actual weight is not reflective of their energy stores. So if we had a patient that has cancer, that has third spacing and edema, what would we use to calculate his needs? Dry weight, or what else? Our ideal body weight. What else could we use? Usual body weight, right? Usual, dry, or ideal. So with biochemical parameters, we're looking at albumin, prealbumin, transferrin, and C-reactive protein. We know albumin and prealbumin are going to be low. What happens to C-reactive protein? Goes up. Okay. Anyone want to take a stab at a diagnosis or a PS statement? These are pretty easy for the cancer one. Okay? Okay.
Inadequate oral food or beverage intake related to the cancer or chemo, I guess if they're on chemo radiation. Okay, as evidenced by, less than.
Yeah. Okay. Very good. Yes, inadequate oral food beverage intake related to dysphagia. Yeah, as evidenced by consuming less than 50%. Yeah. What about the next one? Increased energy and protein needs. What could cause that? That's real easy, right? Cancer could be the cause of that. Cancer could be the cause of that. Increased energy and protein needs related to cancer, as evidenced by, you could talk about like muscle wasting or weight loss. Yes. What lab value would you say for that one? Like your C-reactive protein? Potentially. You could potentially use that. I wouldn't use albumin or prealbumin though, just because it's affected by so many other things. But you could say, as evidenced by an increase in C-reactive protein. Good. So then our intervention is just educating them. And really, with cancer patients, this is kind of a unique population to work with because oftentimes we're telling patients like don't eat too much, or we're kind of restrictive on what we do with them. For cancer patients, we just try to get them to eat. Okay, so it's kind of like the opposite field. So it's not like we're restricting anything, but we really just try to get them to figure out ways to eat. We will potentially educate them on food safety. Why might we do that?
Because if they become infected with like any kind of like food or illness, you're not going to be able to find it all.
Yep. Because what?
Already going chemo radiation.
Yes. Yeah, their immune system is decreased, right? Their immune function is decreased. So oftentimes we're very particular about food safety for these patients.
I was just gonna say, I used to babysit like cousins when I was younger, and their father was struggling with cancer. They closed off like a portion of the fridge just for his food, so that it would be separate from everything else.
Yes, it's very important. Sometimes we forget about that aspect of it. But even in the hospital, when we had patients that were extremely immunocompromised, we had to mask up before we went in there. So we didn't want to bring any infection or any, virus or bug to them. And then with their food, like they couldn't have any like raw fruits or vegetables. They were like on a no raw food diet, so no raw fruits and vegetables. Even things like lunch meat, because it can carry listeria, we had to warm it or they weren't allowed to have it. So it gets very restrictive. And then there was the issue with cross-contamination. So preparing their food separately, and their food would actually go down, be prepared first and go down the tray first for the other foods. Is this related to this?
Yeah, but also no dairy because it's dairy also, or saying that.
Well, I guess because it should be pasteurized, so that wasn't as much of a concern. It was mainly just like the savory. And then we would give it to them, we would just microwave it or warm it first, and then give it to them.
It's kind of related to like the bringing fresh flowers.
Say it again?
Is this also related to bringing fresh flowers?
Yes, so they would be restrictive about what you could bring into the room as well. Yeah, so with those, they would be put like on what we would call like reverse isolation. So not that we would catch anything from them, but just making sure that we didn't bring anything in there. So gowning up, careful about what you brought into the room. Yeah. We'll also see some of these same things when we talk about HIV and AIDS as well, because their immune system is compromised also. So education, diet modification, which is just diet preferences really, like whatever they can tolerate, okay? Usually not a restriction so much, but just whatever they're able to tolerate. And then oftentimes oral nutrition supplements, so supplementing with something between meals just to make sure they're getting the right amount of calories and protein that they need or should be getting. So here's the thing. So that's a really good point. But what do you guys think? What if all they wanted to eat was junk food?
It's a hard deal because you're dealing with cancer. You possibly don't know if they're going to live very longer, and deny them all of that stuff is very hard. And if they're going to eat anything, like you want them to eat, so if they're going to eat, I mean, as soon as it's better than nothing, but then also.
That's a dilemma. I would think, and I agree 100%, I would agree that we probably at that point need to get them to eat anything, okay? I know that there is some thought and there's a lot of research on the fact that sugar feeds cancer. Have you guys heard that before? And I can't say it's not true. There's a lot of research that's pointing toward that direction. But at this point, if they have cancer and they're getting treated for chemotherapy, I think we just have to let them, and we don't know what the results are going to be, like you said, I think we just have to let them eat what they want. We may have to supplement what they're eating with good nutrition, because even though they're eating all of that junk, is it calorically dense? Are they going to get the protein that they need for healing and all that? Probably not. So even if we let them eat it, we probably have to supplement it with things that have some sort of caloric density to it. Usually in a clinical setting, there's not a restriction on carbohydrate or sugar for these patients. It's just kind of a regular diet, whatever is tolerated, just to get calories and protein in them. So even sometimes if we have patients during the day, they eat what they want, and then at night, we give them a tube feeding, so they get something that's a little bit more calorically dense. But I have to agree with you, it's a catch-22. Yeah, we got to get something down them, but I'm not always sure if that's the best thing. But in that situation, you're just trying to get something down. Nutrients.
Is there like nutrition education? I mean, I'm struggling to fully say that's okay. I mean, I understand the needs part of it, but like if they're fighting, unless it's like end-stage cancer, right, and you're just treating kind of like the end-stage palliative care. Like if they're trying to fight it through all of these radiation and chemo, like shouldn't diet be a huge aspect of that, especially if it was one of the ones that is correlated to the diet and lifestyle?
So I'm gonna say that if it were just extreme, they're eating chips and candy and ice cream, yes, that's probably gonna be fought clinically. But if they're eating just like hamburger and chicken nuggets and pizza and things like that, they're probably just gonna wanna get the food down. You understand what I'm saying? Like as far as like if it's just extreme, just ridiculous, then they would say something. But other than that, they're probably just gonna wanna get the nutrients down. Is that the part you?
Yeah, I mean, it just seems like it's two forces that are working against each other in that case. And
I think because, and it's been a while since I worked clinically, but I think because I'm not sure that all doctors and oncologists are 100% on board with sugar feeding foods. You get what I'm saying? I think we're like kind of in a transition period because it's coming out there, and we're like when it first came out there, when I worked clinically, we're like, okay, that's ridiculous. Now we're to the stage where, wait a minute, this makes sense. And then we'll probably move to the stage where we do an implementation. You know what I mean? So we're kind of like in that transitional phase. You know what I'm saying?
yeah, that makes sense.
Do you think right now they're probably doing low carb studies
No.
on cancer?
Yes, they are. There's this very good article, and I forget the name of it, but it's called the Warburg effect. Okay? Are you
Yeah, I have lots of feelings about this.
I was one of those people, and this was years ago when I worked in the hospital. We had one doctor, and he would walk around and he's like, no, sugar beats cancer. And we're all like, what are you talking about? What are you talking about? There was no research to support it at that point. Over the last couple of years, I've also been looking at a lot of research that looks at cancer and carbohydrates and sugars and its effect on cancer cells. And there's a lot of promising research leading in that direction. I just don't know if the medical community is 100% with it right now.
I would say it's context dependent, right? So it's not just like an altered carbohydrate metabolism. There's altered lipid metabolism and like the uptake of lipids from the bloodstream with nutrients and synthesis of lipids, because those cells growing need to make membranes and like structural elements that are based on that. So it's like context dependent, and there's people like looking at low carb diet. For glioma, it doesn't improve survival. Like the ketogenic diet doesn't seem to be beneficial right now. So we haven't seen it. And possibly it would still attempt against them. But for glioma, it's just it's hard. Context needs to be sorted out there. We do have altered effects. So I'm saying like, oh, it's just not no sugar, you'll be fine. Like, all of these medical doctor considerations, it might be a little.
And I think you bring up a good point, because when it comes out, I think you're going to find that it is very cancer specific. I don't think it's going to be like, it'll be very cancer specific. Also, I'm getting old. I don't remember anymore. But yes, I think it'll be very cancer specific once it comes out and once the recommendations come out regarding.
Professor, and if it's like an outpatient, like they're just coming in for chemo or radiation, do they see any dietitians or like nutrition ed on kind of how to just day to day when they're fighting chemo?
It depends on where. Like I know that just in Houston area, MD Anderson has a huge outpatient area. So they do see a lot of cancer patients just as an outpatient basis and how to fight it differently. And what we'll probably see is that in some of those kind of relationships, you will probably get a more specified or specific diet for those patients. Other facilities will do it. I just know that MD Anderson has a huge outpatient program, and they're doing like the cutting edge research. So you're more likely to kind of get some of that education from there versus other places. Yeah, but definitely an area that's gaining a lot of interest in. And I'm going to try to find that article if some of you are interested. There's a real good one on the Warburg effect that I thought was just kind of eye-opening for me. So I'll post that. Okay. Oh, I know what I was going to say. Do you remember in the beginning we talked about with cancer, there's alteration in the metabolic processes? And I think that's what you were saying, how everything is altered. When someone has cancer, the way their body metabolizes all the macronutrients changes, okay? So that may potentially be an area where we're able to be more specific with diet as you mentioned. Yes.
Small molecule research trying to target like alterations in the metabolism. It's basically so like it's all weird, right? The cells doing like crazy.
They're doing crazy things, but you have to think of in cancer, nothing's normal. Everything changes from its normal function. Nothing acts as it normally should. And that's what we have to hold on to, exactly what's changing. Then we can target therapy to treat it. Okay, everything is acting abnormally. Okay, nutrition therapy. We touched a little bit on cancer cachexia, and the next slide shows it. You do not have to memorize this article, okay, or this picture. I just wanted to show you, and the purpose of this is that many factors play a role in the development of cachexia. It's not just one thing. It's many factors that play a role in its development, okay? So when we think of cachexia, it's more than just weight loss. It is the change in the way that the macronutrients are metabolized. It is muscle wasting, fat wasting. Everything changes during this process. When a person hits cachexia, remember I said you can feed them thousands of calories, they still won't gain weight because the way that the things are metabolized are altered at this point. So you can have a cancer patient that's undergoing cachexia, you can feed them 3,000 or 4,000 calories. You're not really going to see a difference in their weight gain or stuff because the way their body is metabolizing macronutrients is completely changed. So one of our goals with nutrition therapy for cancer is to prevent patients from becoming malnourished before they undergo cachexia, to prevent it, okay?
We just do to like, is that the end?
I don't like to say it's the end, but it's really difficult to turn it around at that point. It's really difficult.
It's that aggressive treatment up front and then like,
Yeah, being
reduce
being
metabolism and stuff and like reduce the inflammation a little bit and then just
because we'll see when we talk about cancer or HIV that once that inflammatory process starts, and that inflammatory process is really just the body trying to heal itself, right? So once that inflammatory process starts, it's hard to reverse it, you know? So when we talk about like cancer or HIV or when we talk about metabolic stress, it's so important to catch it early to prevent lean body mass loss. Because once we get to a certain point, it becomes very difficult to turn back, to reverse the effects. Okay, but you don't have to memorize that. That was just to show you that there are many components. So with cancer, we see the cachexia, which they may require nutrition support, so that means enteral or parenteral nutrition, abnormalities in carbohydrate, protein, and lipid metabolism. And then our focus is really on treating whatever signs the patient has. So if the patient has nausea and vomiting, how do we treat nausea and vomiting? If the patient has early satiety, how do we treat it? We focus our treatment on helping the patient. Now I remember the other thing I was going to say. Nausea and vomiting. This is a big side effect of chemotherapy, right? So a lot of times when our patients start chemotherapy, we'll tell them, do not eat your favorite food. Because you're going to hate it afterwards, right? You eat your favorite food and you throw up because of the medicine, you're going to connect your favorite food with that feeling of nausea and vomiting. You're not going to want it anymore, right? So we tell them, do not eat your favorite food. Save that for when you're feeling really, really bad, and then you have that kind of as a resource. Okay? So that's something we can do. It doesn't always help, but that's something. Early satiety, the 6 small meals, diarrhea, oftentimes they get medications for it. Mucositis, we'll usually give them mild foods, mild temperatures, so it doesn't cause any irritation. Xerostoma, we talked about like hard candies, ice for the mouthwash or spray. Constipation, it's usually related to some sort of medication, so we would probably just put them on like a stool softener or something like that and increase fiber if possible. Okay. Weight loss, we want to prevent that as much as possible. And then just knowing the anemia, oftentimes they are given either blood transfusions or medications to improve their or increase their red blood cells. That one. The next one are needs. And so the needs are divided into kind of like how stressed the patient is or what they're undergoing. So that first energy needs, obese 21 to 25, I'll be quite honest, rarely would we use something that low for a patient with cancer. That level may be used for someone that's in remission, okay? So maybe they no longer have active cancer. Or we may see that level used in patients that have had, that are more overweight and have had cancers that don't traditionally cause weight loss, like breast cancer. We know that if patients maintain their weight, they can reduce the recurrence of breast cancer. So that may be used in those circumstances, but rarely probably are you going to see 21 to 25 calories per kilogram for someone that has cancer. Most often, you're going to see anywhere between 30 and 40. Okay, so you're usually going to be at the lower two, the slightly hypermetabolic or those that are hypercatabolic. And when you think of that, someone that's undergoing a more extensive, like maybe they've had surgery, they're on chemo, they've had weight loss, they have malabsorption, that's probably your person that needs 35 or more calories. Your person that's undergoing chemo, having mild nausea and vomiting, hasn't really had significant weight loss, you may give them 30 to 35. Okay? You can also overlap these boundaries. Maybe you have someone that you feel needs like 33 to 38. Don't feel like you have to stay exactly within the 30 to 35 and then 35 or higher. You can overlap if you feel like someone's in between slightly hypermetabolic and severely hypermetabolic. These are just guidelines of where to start. Okay? So when you begin looking at your case study, kind of think about what's going on with the patient. Have they had any weight loss? What treatments are they undergoing? And kind of see how you would fit them in that category. Make sure that you memorize the needs for cancer. Calorie needs and protein needs. Here are your protein needs. We know that 0.8 to 1 is maintenance. You're probably not going to use that very often in cancer patients. We're probably going to either use the 1 or higher. So the 1 to 1.5 for the non-stressed patients. And I don't know if I like the term non-stressed. If they have cancer, they are stressed, right? So this is maybe the cancer patient who's not undergoing extensive treatment, okay? Cancer patients always have some level of stress. Mild stress, that's better.
What is excessive treatment?
So I would say like multiple forms of treatment at the same time. Maybe they've got radiation, they've got burns, they're having nausea and vomiting, they've got significant weight loss, versus just someone that's on chemotherapy with just a little bit of nausea and vomiting. You get what I'm saying?
What about if they're dealing with weight loss, but they haven't
But they're maybe just the weight loss from like chemo and radiation, then their needs are going to be higher, but maybe not quite as high. So when I'm thinking of someone that's maybe had mild weight loss, undergoing some sort of chemo, is that chemo? Probably somewhere about 35, 33, 35. For protein, I'm probably looking at somewhere about 1.2 to 1.5. It's just remember, just having cancer does what to their needs? It makes them increase. Okay, so when you think, okay, their needs are increased because of the cancer, if I have weight loss, my needs are increased more. If I have severe nausea and vomiting, I can't keep anything down, my needs are increased more. If I have burns on my skin from radiation, my needs are increased more. So you have to kind of look at the overall picture and see what's going on with the patient.